Okay, here we go. Ms. Trisha, the floor is now yours.
Hey, good morning, everyone. So I'm going to talk about sterile compounding today. And although I've been in the field for 11 years, I'm not as talented as Miss L and in teaching. So she teaches without really needing any guidance, but I'm going to share my screen with you, and I have a PowerPoint to help me kind of along. Just want to make sure I didn't miss any points. Plus I have a few videos in there and some stuff that I want you guys to visuals that you might have. So I'm going to go ahead and share my screen. Okay, can everybody see it? Did it come up? Am I good? Yeah. Okay. So part of our pharmacy lab skills, we just went over non-sterile when you guys were in the lab on Monday, but we're gonna do also sterile compounding. So when you're in there, or those of you, I know Elizabeth is in there a lot, and then everybody was in there Monday. You saw our, we're able to see our laminar airflow hood in the lab. So we're very lucky to have one of those to practice on. It's very nice that we have an actual one that we're able to practice on, and we don't just have to practice on countertops, because it kind of gives you a real feeling of being in the pharmacy. So here's our objectives for today. I would like us to be able to cover, to understand aseptic technique and its importance to sterile compounding, to understand aseptic hand washing and be able to identify your personal protective equipment as it relates to garbing and by following USP 797 standards, to understand the vertical and horizontal flow hoods and what they're used for. And that's the hood that we actually have a horizontal airflow hood in our pharmacy on campus, and how and why the airflow is different, and be able to describe supplies that we will use during the sterile compounding process, what they are used for, when and why they are used, and understand how to reconstitute a vial using aseptic technique. So this is just very basic what we're going to talk about today. Everything from here on out will just grow on. So as you learn these things, we'll just add new steps to it. You'll learn the process from the beginning to the end. And by the time you're done, you'll be set and ready to take your validation, like you see some of our students have been taking them over this last week. So aseptic technique is defined as being free from contamination. Which causes harmful bacteria, viruses, or other microorganisms, aiming at the complete exclusion of harmful microorganisms. So this is what is different than if you would just compound on a countertop, as opposed to being in the hood. So inside our hood, we have some nice air that's about an ISO 5 class. And what that means is that's just how many particles they allow. So you have your HEPA filter within your hood. And what that helps do is filter out any particles, because particles, organisms can attach to particles and then they can grow. So the whole idea of being able to minimize how many of those are in there is to minimize the harm from the bacteria that we can possibly transfer onto our patients. These medications are going into the body. They're going in through a vein in your body. And so we want to make sure, because you can grow bacteria in your blood just like you can outside of your body as well. And so aseptic technique is healthcare procedures designed to reduce the risk of the transmission of pathogenic microorganisms to our patients. And yes, this is a picture of Miss Trisha in the hood. So that is actually me. At my last job, we did kind of a photo shoot for our website. And so these are not actual, actually the two drugs here are real drugs. That is actually doxorubicin and daunorubicin. But the yellow is actually what Miss L used the other day on your to make sure you were doing the fold and flip method correctly. And you use this also when you get your chemo certification to make sure that you're not dripping. So this fluid is actually, you got vials and ampules. So when you take your chemo certification, you get this substance that will glow if you drip any. So we want to make sure that we're not dripping any cytotoxic or hazardous drugs. And that's because it's harmful to us. I mean, it's not really harmful to the patient because they're getting the drug. But what about the healthcare workers, the nurses, us? You know, if we get that on our hands or transfer that to our clothes, we can bring it home with us and give it to our families. You know, our nurses can transfer it maybe on a chair or a table, and then a patient's family member could be there with them and they can touch it. Now it's been transferred to them as well. So we want to make sure that we are avoiding any transfer, because these cytotoxic agents are just that, cytotoxic. They kill our cells. So we want to protect ourselves. Personal protective equipment, also called PPE. So when you're in the field, you'll hear them refer to it as your PPE. It's designed to protect yourself from patients if they might have something that you could get from them, but also it protects them from us shedding our skin cells onto their product that we're making. So when we use this in the IV room, when we go into the buffer room, the reason we gown up is really just to protect the patient, to keep down that, minimize that particle count. So everything in the buffer room, the ante room, starting from the pharmacy to the ante room to the buffer room, each step you go, you minimize the amount of particles, so that by the time you get into the hood and you're preparing that medication for the patient, you're at the minimal amount of particles. So we wear shoe covers, and this is what you will don or put on first. So putting on your personal protective equipment is also called donning. When you take it off, it's called doffing. I don't know who designed those words, but that's what they are called. I guess I've never really Googled it to see where they came from. They seem kind of silly, but whatever, we go with it. So we put on our shoe covers, then you're going to put on your hair cover. If you're men, you're going to wear that beard cover. We prefer that you don't have, especially Miss L, really have any facial hair, but I know some men do have a beard. So depending on what the policies and procedures are, organization where you work, they may allow that as long as you wear a beard cover. You need to wear a mask and a gown and sterile gloves. If you're doing hazardous drugs or chemotherapy, you're going to want to wear chemo gloves. According to our new 800 standards, that's USP. I know Miss L has covered this. We have the 795, 797, 800. Our 800 standards are really designed to protect the healthcare worker first and foremost. Pardon me. And so our chemo gloves have to be ASTM rated. And what that means is that's the standard practice for assessment of resistance. So the resistance for that drug to be able to get through those gloves. So they are rated in such a manner so that companies can't just make, gloves without having them being up to standards. So USP 800 has designed these standards as a minimum. All right, so now that we're all garbed and we've put on our personal protective equipment, they will show you the putting on your PPE here. I want to talk about hand washing. I know you may think that it's silly. It seems like we talk about hand washing a lot in the medical field, but it really is how we minimize our bacteria and our fungus, especially for IVs. So I'm a very big stickler on hand washing. I always have been, even in my previous jobs. I think that it was really instilled in me very early on. And so it's something that I've always made sure that I've done properly and I don't take lightly. It's really our first thing. The garbing and the hand washing is our first thing we do to make sure that our patients get a sterile product. So I wanted to you to watch this video because it's really not, I don't think it's going to be beneficial if I just explain to you how to wash your hands. And yes, there is a proper way and an improper way to wash your hands when it comes to doing it aseptically. So I'm going to get this, hopefully this video goes. And this is through Johns Hopkins. So none of these are allowed in the compounding area.
Is there an audio to the video?
Yes, you guys can't hear it?
No. Can you guys hear the video, the audio? I can't.
Oh, okay. I don't know how to.
Maybe you click the link and then.
Yep, let's try it that way.
Yeah, close the screen and then share that link to us and then go back to the PowerPoint later. What if you full screen?
Give me a second here.
Yeah. See, guys, say something. If there's
I didn't know you guys couldn't hear.
something. Because we don't know. Yeah, we don't know. I don't know if it's just me who can't hear anything. Okay, so we are each other's checks and balances. Miss Trisha and I are like that. If I did something, I said, can you check it for me? And she did something. It's better to have two sets of eyes, two sets of hands checking. And with you guys, you are a part of it. You should be part of the checks and balance that we're doing. And it's the same in a pharmacy, okay? You have to remember it's the same in a pharmacy.
Give me 1 second here again.
My suggestion is to click that link.
I'm trying.
Yeah, copy it in a.
Yep, I'm pasting it. Yep.
Yeah, in a tab, and then you might have to exit this screen and then share that screen that has the video.
I have to get back on here with you guys.
I can help you if you paste, if you're having problems.
No, I got it.
Oh, great.
Give me a minute. Give me a minute.
Sure. Let me know if you need help.
All right, can you see that one?
There you go, perfect.
Can you see the new screen?
Yes. Okay. You want to full screen it?
It is. Let me see.
Is there still audio? Is there
no audio?
No audio.
This is the actual one that's stuck.
Okay.
All right, there's really just music to it. There's no talking. So that's the only thing you guys are missing is the music.
Oh, okay. I thought there's
No, you just have to read.
Okay, maybe just make a commentary as she's doing stuff.
Yeah, I'm gonna start it. Okay.
Perfect. I'll mute myself.
So these are all everything that is not allowed for you to bring in the clean room with you. Leave all those at the desk. So you're gonna put your shoe covers on at the line of demarcation. That line is in the anteroom, and it separates the clean side from the dirty side of the anteroom. Going to remove all of your jewelry, any bracelets or watches. And now you're going to put your hair cover on. She's putting 2 on. If your hair is heavy, you may need it. Put 2 on in order to keep your hair in. Cover all your hair. And then your mask.
Make sure ears are covered as well, okay?
Yes.
I've seen some students who just put it behind their ear, okay? Ears must be covered.
So these are our nail picks. Not everyone, they're supposed to actually, they are required now to use them according to 797, but not everybody carries them. You're gonna make sure when you do pick your underneath your nails, you wet them under the water just like she did. And you do this before you wash. We're going to make sure too, you don't have your nails aren't going to be any longer than a 1/4 inch from the nail bed. No nail polish, no artificial nails. She's washing her hands and her arms all the way up to her elbow, starting from her hands up to her elbow. You will wash for 30 seconds at a minimum and then rinse. You're going to rinse from fingertips to elbow. Even though you've just washed your hands, they still consider the elbows dirtier than the hands. So you're going to dry the hands first and then to the elbow, and do not go back. And now this is when you put your gown on. And now she's going to use alcohol-based hand sanitizer after putting her gown on, since she touched the gown. And then once it's dry, she'll be set to put her gloves on, and now she's ready to go. Make sure your glove goes over the cuff of your sleeve. That way you're not shedding any of your skin cells from any thing. You don't want any of your skin showing. All right, so I'm going to stop sharing this one and go back to this one. All right. Does anybody have any questions so far? Oops. Uh-oh. Hold on a second. It's talking to me. You guys probably can't hear it, but there you go. All right, sorry about that. Any questions, anyone? On that process? Did everybody understand?
Yeah, I saw that she used one paper towel for both arms. Wouldn't it be more advantageous to use 2 paper towels? Because
You can.
the first one is dirty, you know, you're drying it, it can get dirty, correct?
Well, she dried her hands first if you watched, and then she dried each arm. So she didn't go back. You know, had she done hand to elbow and then hand to elbow again, yes, but she did her hands first and then each arm. Okay. I'll tell you what, you're going to need multiple ones because ours are like so thin in the pharmacy that you'll need more than one. So you won't have to worry about that. But I don't think they don't allot you the paper towels, and you won't actually use a paper towel. You'll use a lint-free wipe. So in order, you don't even keep paper towels in the ante room. We don't use those past the pharmacy area. Yeah. So yeah, that's good, Elizabeth. And however you feel comfortable, as long as you're not going over it again, if you want to use one for each arm and you feel better about that, that's fine. Absolutely. Okay, so now I want to talk about the hoods. There are really 2 different type of airflows when it comes to hoods. There's many different type of hoods because you have hoods that are designed for non-chemo meds like antibiotics and TPNs, and then you have hoods that are designed for hazardous meds as well. You also may have, because some places might not have the availability for a buffer room, they'll have a hood that actually is a closed, they call them glove boxes. So it's closed off to the room itself. So all the air inside of it is the ISO 5. Hold on, okay. And so, but the main two types of airflow and the ones that we're going to talk about today are the horizontal airflow and the vertical airflow. So no matter what your hood is, it'll have one type or the other. And so the difference between the horizontal airflow, and that's what we have in our lab on campus, is a horizontal laminar airflow hood. And its HEPA filter is in the back of the hood. So if you look at the back of the hood, you'll see that it has, it's actually more open. Some of them are more solid. They're a stainless steel with tiny holes in them, but ours is actually a more open grate. The HEPA filter is behind there. So one thing you want to be cautious of is you never want to get any product on that HEPA filter. So you don't want to spray alcohol in there. You want to try to obviously always have control over your medication, your drugs that you're drawing up in there, as to not saturate that, because that could it won't work properly basically, and it will need to be replaced, and they are very expensive. So the HEPA filter is in the back. So that's where our air comes from. So our air is sucked in through the hood, or however the hood is designed, and it goes up into the back, comes out of the back of the hood, and is sent through that HEPA filter. So it's filtrated, and that is the most clean air, as close as you could get to the filter. So that's why when you are going to be making medications, you're going to hear us talk about having to stay 6 inches within the hood. The reason you're going to do that is because that's where the air is the cleanest, because it's coming straight from the HEPA filter. So that's also called first air. You'll hear that term as well. So it's suggested that the hood remains on at all times. We don't leave ours on because it's extremely noisy, and we would never be able to hear Miss Al talk because it is very, very loud. But most hoods, wherever you will work, they run 24/7. They don't shut them off, but sometimes you may need to shut them off for them to be serviced. They'll shut them off probably to change the HEPA filter in them, or if they need any work on them. Or if you lose power and it goes off, that may happen. That happens often, and you will need to run it for 30 minutes then prior to using it. So it needs to circulate that air back through there, get that particle count down. You're going to also make sure that you clean it. If it shuts off and you have to run it for 30 minutes, you're going to run it for 30 minutes and then clean it before you use it. Give it a nice thorough clean. So it also, the hood has to be cleaned every day or before each shift. And then the new standards, according to 797, are every 30 minutes throughout the compounding day. So if you're in the middle of compounding something and you're right at that 30 minutes, you can finish what you're compounding. And then when you're done, you just need to give it a full clean again. And that's just with your isopropyl alcohol. So this hood, the horizontal airflow hood, is used to prepare sterile products, such as IV antibiotics and TPNs. So TPNs are total parenteral nutrition for our patients who, for some reason, are not able to eat, whether it's due to having surgery on their gastrointestinal tract, or they have cancer and they're vomiting and they can't keep anything down. Sometimes our pregnant women who just we call them pregnant pukers, because they just can't. I know it's horrible, but that's what we call them in home care. So we have our pregnant pukers, and we have to give them TPN. They'll get actually all the nutrition they need directly through an IV that they have, and they actually place that, kind of like if you were going to have chemo, they place that temporarily until she either gets better or has the baby. And so, just like I said, you must stay 6 inches inside of the hood to remain sterile. That is because of that air coming out of that HEPA filter. Vertical airflow hood. So this hood is designed a little bit differently. So you'll have to be cautious when cleaning it because the filter is in the top of the hood. And so the air is going to come down, and that's why it's vertical. So horizontal is coming out towards you and the vertical comes straight down. That air is designed in such a way to be able to keep, it's used for hazardous drugs a lot. So vertical air is used for hazardous chemotherapy, and that's going to protect you because the way the air comes out, it never comes out the front of the hood. If you use horizontal, it would just push all of those chemicals out right at you and into the buffer room, which would be very harmful to you. So the vertical air is designed to come down, and then it's actually sucked back into the hood, usually underneath, and it goes out. And according to 800 standards, it needs to be ventilated to the outside area. So there's no, I know in the past, when I first started my last job, we were in a building that it wasn't ventilated to the outside yet. They weren't up to standards. It still would come, it was vented just into the room. So that could be very harmful to the healthcare worker over time, you know, those fumes and getting those toxins. Just like the horizontal flow hood, it needs to be cleaned. It also has to be run, and it runs 24/7. It won't be shut off, and it must run for 30 minutes before using, if it's been shut off, and then thoroughly cleaned. And it needs to be cleaned before each shift and every 30 minutes throughout the day. This one has an extra step. If you're preparing any hazardous drugs, chemotherapy drugs, anti-neoplastics, you need to do an extra step every day and do a deactivation. So we have chemicals out there that are used. We used one called Paradox. So it was a combination of sodium hydrochloride and hydrogen peroxide, I believe, and those two chemicals together would deactivate the chemotherapy. So you need to do that step. And if you have a spill, if you drip, which we won't do that, right, Miss L, because we're trained better and we're going to train you to not drip. But if for some chance it happens and you would drip chemo, you just want to make sure that you use that right away to clean up that spill. That way it's not transferred onto the IV bag or onto your gloves, where then you can transfer it outside of the hood. This one also, we ask that you stay 6 inches within the hood for the cleanest air. Okay, any questions about the hoods? That's a big one. There's a lot to know about that, and you'll learn too. There's a lot of different types of hoods that you can use. And they all have letters, you know, you're going to hear CACIs and, you know, the BSC, which is biological safety cabinets, and you're going to have Class A and Class B one. So there's a lot to learn. And if you read the chapter, I believe it's chapter 13 in our textbook, that gives you a lot of good information on the hoods. It kind of it goes further than what we've talked about. So you'll be able to understand when and why you use those hoods better. So I want to talk about what we're going to need. So now that we've already been in, we've gowned and we've garbed and we've washed our hands and we learned about the hoods, and now we've cleaned the hoods, it's time to make some meds. So we're going to need some supplies. We're going to need syringes and needles. So I want to talk about those. Those are two of the supplies that we're going to use. So this is our syringe. These syringes come in a bunch of different sizes and for different measurements, because you will measure from very small to very large in size. And so here is our syringe, and our syringe, we have to be cautious of what we touch, because we have areas called critical points on all of our supplies that we use. And the critical points are points that we're going to enter that could possibly cause contamination, be a site of contamination. So on the top of this needle, this one has a lure lock attached. So we have slip tips and lure lock syringes, and we in pharmacy use the lure locks. They use the slip tips for other things in medical, but we use the lure locks. And that tip at the very end is considered our critical point. So when opening up the syringe, you want to make sure that's covered before you set it down on the hood. You want to make sure it's pointing towards the HEPA filter, so it's getting that best air, and you don't want to put anything in front of it. And we'll learn all about that too, not blocking airflow and not shadowing and whatnot. And then we have the barrel. The barrel of your syringe is fair game. You can touch that. That's not at any time anything that's going to come in contact with our drug or our IV bag that's going to cause contamination to the patient. So also the barrel flange, you can see that little flange area at the end, bottom part of the syringe. You can also touch that. And your plunger flang, you're going to be able to touch that as well, but you will not touch the plunger. The reason you're not going to touch the plunger is because you can see it goes in and out of the syringe. So that can be a source of contamination. If you touch it below there and it goes up into the barrel, then it can have contamination from your hands on it. So we want to make sure that we don't touch that. Our needle, oh, yep.
If you need an arrow, because we're not in the classroom, we don't have a pointer.
Yeah.
Let me give you a tip. There is an annotate button in there, and you can choose arrows and you can point directly. I don't know how they're seeing the screen. To me, it's fine because I have a big screen, but you were pointing at the flange, at the critical areas. You can use that arrow. Did you see the annotate button?
No, I don't.
Okay. When you're on screen share, I think, because I don't have it right now.
Is it in?
Because I'm not the one sharing the screen.
Mm-hmm.
Annotate. It's okay. I can teach you that later.
Yeah, I was just looking real quick for it.
Yeah. Just in case you need arrow to point out certain things, if we have drawings or pictures. I just learned that recently too. Don't get me wrong, I'm not an expert on Zoom.
I'm not either.
Yeah, but in case you needed it, so it's there.
Can you see my point? Can you see my pointer now when I'm pointing it?
Yeah, we can see your cursor now. That will work.
Good. Can I use? I'll just use that. How's that?
Perfect.
I didn't know if you could see that or not. Okay.
Can you guys see it? I can see it. I can see her cursor.
Can you see my cursor? Okay, good. All right, so now we have a needle that we're going to attach to our syringe. And so this part here is the hub. That's the actual part that is going to, you're going to put onto the end of the needle on that lure lock end. And then that little piece right there is the hilt, and that attaches, that's the base of the actual shaft of the needle to the hub. You have the shaft, and so the shaft is the actual metal or needle part of the needle, and the lumen's the inside of it. So the shaft is the outside, and the lumen is the area that's hollowed out inside, and that's what what's going to draw your fluid up into your syringe. And then all your needles are have a bevel on them. So this is how they are shaped. You have a tip here or a point, and this part right here is your bevel. So this is going to be important in two ways. You're going to make sure you bevel up when you're going to put your needle into your vial to draw out. And then when you draw out of an ampule, you're going to want to make sure your bevel's down. So bevel up on a vial is to help make sure that we do not core. And that means take a piece of that rubber stopper with us and put it into the fluid. If we do that and then it's drawn up and put into the IV bag, then that can be infused into the patient, and that's not good at all. Okay, So our syringes come in different sizes because we're going to drop different amounts of fluid. Drug is going to come in different doses. So according to doses, we'll know how much volume we're going to pull up. So it can range from 1 to 60 mLs. Those are our size syringes. So if you have anything greater than that, you'll use multiple syringes. And our 1 ml syringe, you know, it goes down to 0.1. So you're going to select your syringe. The capacity is the next size larger than the volume to be measured. We have a rule that you do a 20% minimum, 70% maximum on our syringes for how much fluid. And that is so minimum. The reason for that is because accuracy. You're going to want to make sure that your volume is accurate, and using a syringe closest to your volume is going to be the most accurate. And the maximum is to make sure that that plunger, so this plunger here, can actually pull all the way out. If you pulled that, this seal right here, it'll stop, but if you pull hard enough, it will come out. So we want to make sure that we don't go far enough down that might cause that to happen. So we're going to do it at 70%. That means if your drug is 10 mLs, you're only going to pull up 7. And so this is, in this way, the graduation marks on the syringe would be the smallest possible increments for the volume measure, and that's for accuracy. And the syringes should not be filled to capacity because the plunger can be easily dislodged. So pulling out, they call that dislodged. So our needle sizes. So our needles come in different lengths and gauges. So length is how long it is. Gauge is how thick it is. So the length of the needle is measured in inches from the juncture of the hub. So if we go back here to the hub and the shaft to the tip of the point. So if we go back to our needle, so it's measured from the hub to the tip. That's going to give us our length. And it's measured in inches. This one is 3/8 to 3.5 inches. That's going to be what our needle size will come in. Some special use needles are even longer than that. Wow, that doesn't sound nice at all. I don't think I'd want somebody sticking something longer than 3.5 inches in my skin, my body, my arm. The gauge of the needle designates the size of the lumen. So the lumen, remember I told you, was the inside of the needle, what it's gonna hold, what fluid it's gonna hold, and it ranges from 27 to 13. Now the 27 is the finest. So even though it's the larger number, it's the smaller. So the gauge of the needle is 27. That's going to be a very small. And then 213 is the largest. We typically use 16 and 18 when we're drawing up our meds. So those are our most average size needles. So there's 2 considerations when choosing the size of the needle, and that's the viscosity of the solution. And that means whether it's thick or thin. Sometimes they're sticky as well. And the nature of the rubber closure on the container. So that's like what you're going to, the vial that you're going to enter. The needles with larger lumens should be used for viscous solutions. So those thicker solutions. So that's why I told you sometimes we use 18, sometimes we use 16. Smaller gauges needles are preferred if the rubber closure can be cored easily. And you'll learn that different drugs, and you'll learn by it happening, just like we do everything in life, unfortunately, unless you have somebody saying, hey, be careful, this is going to happen standing next to you, which we do that as technicians. We are always very good about giving advice to those around us. Hey, be cautious of this. Hey, watch out, this drug does that. Because we've all been through the hard part of it when you core something and now you got to filter that out. So, so we talked about coring, and that's when the needle punctures or tears a piece of the rubber closure, and then that piece falls into the container, and that creates a particle, and that's a material that can possibly harbor contamination. Whoa, So here's another needle that we have. This is a filter needle. A filter needle we're going to always use when we're drawing out of our ampule. And why is that? Can anybody, here's our ampule. Here's an ampule. Can you think of why you might need to use a filter needle?
In case you might get a piece of glass in it?
Absolutely. That's exactly why. Because some drugs have to come in ampules because of the way that the drug is designed. And so, yeah, we will have to break this open, and breaking glass means you will have some shards, possible shards in there. So you always, always, always use a filter needle when drawing from an ampule. Now you can choose to use it when you're drawing from the ampule, or when you are putting it into the bag, but not both. So you're going to never use the same needle to do those two tasks. You're going to use the filter needle or the regular needle to draw up the solution. And whichever one you don't use, you use the opposite to put it in. So if you choose to use a regular needle because it's easier for you to draw it out of here, you just need to make sure you filter the drug before it goes into the IV bag. If you choose to use the filter needle to draw it out of the ampule, then you just need to make sure that you use that regular needle to go into the IV bag. So here's our filter needle. It has, the only difference it has between a regular needle and this one is it has a filter in here. So it's usually a glass filtering device that's in there, and it's at 5 micron. When there's different micron size filters or different size filters according to what you have to filter, and most drugs will let you know what size you need. This is another one of our supplies. This is a double-sided needle. It's used to transfer the contents of a vial into a bottle. I don't think this is used that often. Miss L, did you use this one that often? Did you use the this type of transfer
needle?
Yeah.
No, I only have one in the pharmacy,
Yeah.
just to show them, because we're not having them do the add a vial, we're not having them do the transfer needle. We're going to have them use regular syringes and regular needles, because we don't always have the luxury of this. What if we run out? What if we go out of stock in the hospital, which Ms. Trisha was talking about? And we will keep telling you this. It's okay to know how to use the basics and the regular ones, so you're not stuck and disabled when this go out of stock or out of your supply.
And it happens all the time. Things go on back order in pharmacy all the time. Drugs, our electrolytes, certain drugs, and obviously our supplies go out of stock often.
Having our system or the computer down alone is frustrating already.
Oh my God. Yeah.
Yeah, because you can't do anything now without the system being up. So luckily, it doesn't go past an hour. I've never experienced that a system goes down past an hour or 2 hours. It's not going to go on for an entire day unless something really big happened. The IT or whoever service provider you have for the software tries to fix it right away, because they know when the system is down, everybody's down.
Oh yeah, right? And they know that if that's down, we can't take care of patients. They get on it fast.
Yes, they get on it fast. That's why I said I don't have an experience where it's down more than 2 hours. Probably,
and it's similar with me.
Yeah, probably 3 hours is long. That's long.
That is. That's like a half a day. That's almost a half a day.
Yeah, in that 3 hours, patients may die. A lot of patients may die because of that. Remember, because we receive stat orders all the time.
Absolutely. Thanks, Miss L. Okay, here's another. These are your friends. I love these. They come in chemo and non-chemo. I know Miss L's laughing because when we compounded for a long time, or we're compounding a lot in home care, I told you, depending on how the prescription's written, we make a 7-day supply for patients typically. So that means we're making, multiples. We're making, 7, 14, 21, 28 plus of some meds for each patient that we're making meds for. You're making 7 TPN bags, not 1. And so this device is so nice. Now this one is actually chemo. It has this flat little vent on it. And the reason why is it'll hold some of that chemo in there, and it doesn't let it go out. The regular dispensing pin it's a chemo venting pin. We call them dispensing pins as well, are almost exactly the same. The filter's just a little different. And the nice thing about this little piece of heaven is that you can stick it in your vial. I know it filters the air for you. You don't have to worry about bubbling. You don't have to worry about negative, positive air pressure in the vial. And that's what we're going to learn about, all that fun stuff in the lab. I can't wait, you guys. I'm so excited to get you guys doing that. It's so much fun to be able to get in there and do hands-on. So we use needles because these go on back order all the time. So you need to know how to do it what we call old school, and that's with the needle. And so now with 800 standards, they have new closed systems. So we're getting away from the needles and when it comes to chemotherapy and hazardous drugs, but there's always shortages, there's always back orders, and we need to know how to do it safely and do it without these devices. All right, so here is a vial. So I chose a vial of Remicade. This is a drug I've used for a really long time. A lot of our patients have Crohn's disease, ulcerative colitis. They do use it for use for, I believe, rheumatoid arthritis. Now they're finding they've had it. Some people with lupus, they find different things like autoimmune disorders that these drugs end up helping these patients out. So this is what our vial looks like. So this is our vial. It has a nice little top on it. You're going to flip that top off, and underneath there is a rubber stopper. And that's where we're going to enter our vial. So how do you know how much or how you're going to reconstitute your drug? Say you don't have a nice little cheat sheet that somebody has there ready for you. And so how would you then decide, what am I going to use? Sterile water? Am I going to use normal saline? What am I going to do? I don't even know where to start, right? Well, we have these nice little things called packet inserts, and they come right in there with the drug, or you can Google it. But if you're in the ante room already, you obviously probably won't have a computer there with you. And so you can open this packet insert up, and I hope you guys are able to see this, Miss L. I just wanted to show you guys what a packet insert looks like. I'm sure you guys have all looked at it. Okay, so here's our packet insert for Remicade. Can everybody see it?
No,
you have
it's not
to
coming up.
Yeah, you have to stop share the PowerPoint,
Dang
then
it. Okay.
share the PDF because it's a different program.
Okay.
Every time you change program.
Okay.
You have to
Well, we don't have a lot of time, so I won't do that.
That's okay. My math is short today.
Okay. Okay.
Keep going because this is important information. We're finishing up pharmacy lab skills today.
Okay. Give me a second here.
No problem. So we can just do the review on Friday. This is all good information. I'm actually going to update the Udemy USP 797 class and include this because these are all good information that Ms. Trisha prepared for you guys. And Ms. Trisha and I are going to update the video once we're both back in the campus next year. And Ms. Trisha will be the one doing the demo based on the newest USP 797 standards. So you have an updated one because Ms. Trisha and I always discuss this thing. Oh, the book says this. However, this is the updated one. You have to remember that the IV certification that you're doing through the NPTA hasn't been updated based on the latest USP 797 and 800 standards. Okay. So
can you guys see it now? Are we good? Can everybody see it now?
Very small, but we can see it.
Oh, shoot. Okay.
That's okay.
All right. So this is our packet insert. This is for Remicade. I chose a Remicade. So this gives us a lot of information, but as a tech, you're just going to search for what you need because you're really not going to really need to know what contraindications. You're not going to indication for use. I mean, it's not going to truly matter if you know if it's used for Crohn's or ulcerative colitis. I think that's fun information. So I always read the packet inserts, but I'm kind of weird like that, me and Michelle.
It's not weird. It's actually when you're asked, what is the best reference for a drug? And the answer is no other books, no internet reference. It's actually the drug's product insert. It's the drug's product insert because it's the manufacturer who actually made that product insert. So it's based on their clinical trials if it's the original manufacturer who did that. So when you're asked what's the best reference for a drug, it's the manufacturer's product insert. No book can compete with it, okay? No reference can compete with it. So yesterday, I just wanted to share, I was in a chat room with my friends who are pharmacists, and we're following the development of the COVID-19 vaccine. And of course, because Moderna's a vaccine, and then Pfizer has their own, and then there's a Russian brand, and then there's another one that's coming up. We were comparing, okay? And speaking of product insert, you will have to read those product inserts, not only to know the storage condition, but to know the pharmacokinetics, the pharmacodynamics, all of this. How does it come available in? Because there are vaccines for COVID that are live virus, okay? And there are vaccines that are not live, okay? Because not everyone, but manufacturers or pharmaceutical companies are trying to develop these vaccines as fast as they can. Some got to the third phase, some didn't. Okay, so as pharmacists in our chat group, we were looking at the development of each brand or from each manufacturer. Okay, so FDA, just a fun fact news, FDA just approved Pfizer's. Okay, so we have Moderna and we have Pfizer's, I don't know the brand. I should look it up. The brand for Pfizer, I forgot. And I was told by my friend in Dubai that they're actually using another one now. I gotta look it up, and it's open to the public. The public has access to the one in Dubai right now, okay? And I know that Philippines is gonna start off with a Russian one, okay? So that's what's going on in the world now, but we always go as pharmacists, Ms. Trisha, we go by the manufacturer's product insert to know information about the drug. Okay?
This is my go-to. And I always pick the one that's actually, I find it to be best, and that's where I got this one, was off the FDA website. That to me is always the best, because sometimes if you go to the actual manufacturer's site, you don't get all the information you need. So here it tells you, just so you know how to use it, it'll give you a little, it'll show you where you can find certain things. You see where it says number 2, dosage and administration. So we're going to look for, sometimes it's under dosage and administrations, and then, or it'll talk to you, it'll be about use and administration. And that's where we're going to find our information in there. So it's going to tell us how we're going to use it, what we're going to use to reconstitute it with. So this is actually, you're going to use 10 ml of, it's actually compatible with normal saline and sterile water, but they like reconstitution to be done with sterile water. When I first started making it, probably 11 years ago, we would just use this normal saline out of the bag and reconstitute the vial with that. But then they had some changes, but it still is compatible with both. So if you have to use normal saline, and it tells you that, compatible with, so use either or. You're going to use 10 ml. So you're going to put a full 10 ml in there. So you're going to get a 10 ml out. And I know I was talking to them in the lab the other day on how when you put in that, whether it's 9.6 and it's going to yield 10, there's some drugs that you're going to put in 10.2 and it will truly yield 10. So I cannot figure out miraculously where that 0.2 goes. None of us know. And you had powder in there, but it really does happen. So we have some drugs that are like that. And we're like, really, you know, where in the heck does that 0.1 or 0.2 go? But, and then you may have some that the powders actually, I'm assuming it has something to do, obviously, with the molecular makeup, the structure of the drug, because then some of them you're going to put less in and you yield quite a bit more. So I say go to your packet insert. It will give you anything that you need to know. If you are concerned on whether what you're putting it in, it may not be compatible with that, because you might get asked that. In my last job, I was always asked that by the doctors. Is this drug compatible with D5? Can I give the patient, because the patient may need, you know, some glucose. So can I put this in D5? Is it compatible? And you're going to have to find that out. And you're like, okay, yeah, packet insert. Go to the packet insert, you find the doctor, their information, and they're going to think you're great. So, well, hopefully they're going to think you're great.
It may be called packet insert or product insert. Okay, both.
Okay, give me a minute. I think I have to open up my PowerPoint again now, because I think I closed it down.
I know
I'm
that
almost
happens to me
done, guys.
every time I open something, and then I have to remember that if it's a different program, I have to close and open that
No, now I have to figure out how to find you again. There we go.
PowerPoint.
There we go, guys. Okay. 1 second, share screen. All right. So we are down to here. So excited. Now we're down to the actual reconstitution of the vial. So we know what drug we need. We've decided what fluid it's going to go in, because that packet insert will also tell us how much max minimum that the drug can go in. So according to what the doctor has called for, we'll want to check that too. You know, we call it COA. We cover our butts. And so we like to make sure that we know what something's going to go in, it's compatible with that. So we found out what it's compatible with. We found out what to reconstitute it with, how much that it will yield. So we're going to be able to figure out our math, because we know it's going to be 100 milligrams per 10 ml. So we're going to be able to then go whatever dose that doctor calls for, we're going to be able to figure out. So we're going to do our math. So like I said, we're going to choose our diluent. So that would be our normal saline or our sterile water. In this case, we're going to use sterile water. So we grab that. We know it's going to be 10 ml. So we gather all our supplies, because now we know what size syringe we're going to get. We're going to remove that top of the vial. And very importantly, because that is considered, after that tab comes off the top, that's considered a critical point. That rubber stopper is a critical point. You're not going to want to block airflow to that, and you're going to want to make sure that you alcohol that with isopropyl sterile alcohol. We're going to use a wipe. You're going to use just one side of the wipe for one vial. So if you swipe one side, you can turn it over and use the other side for a second vial, but don't ever reuse them again after that. So we're going to attach the appropriate needle to the syringe. So Remicade isn't very viscous, so we'll go ahead with our 18 gauge needle. And we don't need a filter needle for this, because it's not in an ampule, and we haven't been, some drugs we do have to draw up with a filter needle. If they come from other countries, our FDA might not consider them to the standards that they should be filtered to. So a lot of times we ourselves will have to use a filter needle. But this case, Remicade is not. We don't need a filter needle for that. So we're going to reconstitute it with 10 mLs. Then we know how much the doctor has called for, because we figured out our math. So we're going to go ahead and we're going to say the doctor wants that whole vial, 100 milligrams, which isn't a lot, because it's weight-based, the Remicade is. So unless it's a very small child, it won't be just 100. People, we have, in adults, you may get up to 1,500 milligrams. So that's going to be 15 vials that you're going to have to reconstitute and draw up for this patient. So we're going to hold the syringe, and we're going to do, I'm just verbally telling you all this, but we will do this all in lab. Okay. So it probably will be kind of like, unless you've been in there and watched it, you're going to be like, whatever, you can read it, but until you get your hands on and see it, you're not going to understand. But I wanted you to have the information. So you're going to hold the syringe to the vial at a 45. Watch Elizabeth. Yep. We're going to be at a 45-degree angle, right? Oh, you know what? I have my supplies, Miss L. I still have my supplies. All right.
Yep, you should be picking up your supplies soon because you're doing PHA 225. So Ms. Trisha and I will release your supplies so you can start practicing. Perfect.
Okay. So I have my vial, okay, and here's the top. I've already alcoholed it off, and I have my syringe and my needle. My bevel is up. I know you guys probably can't see, but that means that it's like a little, I don't know, how do you explain what?
Ms. Trisha, I think for you to be bigger on the screen, why don't we take that PowerPoint off?
Okay.
So
And
it's just you.
Yep, and we're done. This is the end of it, guys. So
oh,
yep.
okay.
This is my last one. Yep. How's that? Okay.
Perfect.
All right. So we have our vial, guys, and we have our syringe. So this is your bevel on your needle. Can you see that? I'm just going to turn it. See that bevel? We're going to do bevel up, okay? And I'm going to turn this so that I can set this down. It's always important you set it on a, I don't know, can you guys see? I don't know if I can do this or not. There. Can you see it? All right. So I'm going to do bevel up, and this is a 45-degree angle. So I am going to just barely pierce that rubber stopper at the 45 and turn it into a 90 and then go in. Did everybody see how that went? This one's very, very hard to get into. So we got at a 45. We're going to pierce it a little, not a lot. You don't have to be rough, and then go into 90.
That is tough.
Yeah, did you see that? That one is rough.
I saw that.
Yeah. So, but anyway, that's how we enter the vial. Okay. And so we'll work with airflow, positive, and negative pressure, because that's going to be how we draw out of the vial. So our vial here has either positive or negative pressure in there, and you have to make accommodations for that. That means whatever liquids you take out of here, you need to put air into it, right? So you're going to draw air up into your syringe, and as you draw the fluid out, you're going to put air in, draw fluid out, put air in, draw fluid out, put air in, draw fluid out until there's no air left and you have your correct amount that you want, okay? Now, if you still have...
Can you clarify again the positive and the negative pressure? Because this is always a point of confusion.
Okay, negative means there's no pressure at all. Positive means there's air in there. So if you put air into something that already has pressure, what's going to happen? The air / liquid is going to try to come out of the vial. So that means when you're trying to pull out that fluid, if there's too much air around that needle, fluid is going to drip out. And so drug is going to drip all over. If you don't have any air in there, that means you're not going to be able to pull anything out. It's going to be almost vacuumed. You know, you're not going to be able to pull anything out because you don't have anything to give it back, right? Because there's no air in there. So that means you have to replace that air to take your liquid. So that's the difference between negative and positive pressure. And once you start doing it, it'll make a lot of sense because you'll be able to actually feel it. Once you get in there and you start doing this, all of this will come together and make sense. So I'm very excited to be able to start working with all you guys. I know, Elizabeth, you've been in there and you've kind of got to observe a lot of it. It is very intense, right? Especially where they've been at right now because they were getting ready for validation. It's always very nerving, right? And plus, they were trying to make up for time. And so, it'll be different. You'll have a lot of your hands-on, as long as you keep practicing, coming into your labs and stuff, then as you practice, you'll just get better and better. And that's the only way that you can do it, is by practicing.
It was fun watching them.
Yeah.
I was able to observe and learn a lot just by watching them.
You do. And it's funny though, because by watching it, you're like, oh, that doesn't look so bad. And then you get in there and it's like, oh no, it's like totally different, isn't it, Miss L? It is like, and then being watched, I don't know about everybody else, but being watched for me is like, I'm like sweating. It depends. Like if you have JCO coming in, Joint Commission, and they're like standing over your shoulder. It's like, I've been doing this for 11 years, but you're like, oh my gosh, and it's like all of a sudden you forget how you're supposed to do things, and you have no fingers, you're just all thumbs.
Right. You can tell how old school we are because Miss Tricia still calls it JCO. Sometimes I slip. It's TJC now, the Joint Commission, and you've learned that in law and ethics. We're so old school that we use terminologies in the past. They just changed, the organization just changed their name. So when you hear the word
they grew, right? They expanded.
TJC or the commission's going to be coming for audit, then it is true. Even if you've been doing this for 20 years, 30 years, when somebody's behind you watching you, it's nerve-wracking. Okay. It's nerve-wracking. That's why students, like after 20, 35 hours of practice, they're going to say, oh my gosh, I got this. And then I stand next to the student or behind the student. And then all of a sudden you lose everything. Okay.
Absolutely. I totally agree.
Everything.
Like you haven't done it like a day in your life. Yeah, I know. It's crazy. Yeah, absolutely. And so I really commend, all of you guys for doing this. You'll get comfortable with me though. That's the nice thing. You do get comfortable with who you're working with. It's just that initial sense of nervousness. Plus, if you're being tested, there's all something about that too, just knowing that you can't make that mistake, it's like all knowing that you can't do that.
Students think that, it's more difficult. She's the program director, right? I don't want to be validated by Miss L. I want Miss Tricia to do my validation. But let me tell you this, Miss Tricia's tougher when it comes to validation. Okay. She'll message me and she'll tell me, will we accept this? Because in practice, this is it. But the book says this. We have a lot of discussions like that. And with the ever-changing, the many changes that happened in 2019, 2020, and then 2021 with the USP 797 and USP 800, Ms. Tricia and I will have to be updated too. And we're going to have to make that decision to teach you guys the more updated information when it comes to USP 797 and USP 800. So I'm really very excited. So don't think that, oh, Miss L is tougher. I don't want to be validated by Miss L. Miss Tricia's her assistant, so I want to be validated by Miss Tricia. But I was watching her do the validation and I was like, oh my, I said, you do the validation, you're tougher. But she's going to be at the labs with you. We don't know until when, okay? We don't know when we can be together for a long time. Like Ms. J and I used to be every day. I wish I could do that. I'm there at the campus once a week, sometimes twice a week. I miss those days. I miss those times. And it's so much easier when we're at the campus. When Ms. Tricia and I see each other at the campus, it's like, oh my gosh, we want to spit out everything that we needed to tell each other, okay? Because there's just no time. Even if we meet online all the time, it's just so difficult. But with you guys around, you're going to see that we struggle every now and then too. We're human. Sometimes we ran out of this, or we'll get a vial that's defective, okay? And we're not going to put that against you. We're not going to take that against you if you get a defective vial. You have to remember that our vials, all of them are demo drugs, okay? So they may not have gone through the usual quality control testing that manufacturers or pharmaceutical companies do. Some aluminum wraps may come off, the rubber may come off. Will we fail you for that? No, we're not going to fail you for that. We understand that. But even in real life, we'll get vials like that every now and then, okay?
So we just had that, Miss L, with our hazardous. It was the rubber stoppers were leaking when Julio was doing his validation or practicing for his validation. He was showing me, because him, he doesn't drip anything. So I took the vial and I'm like, one needle stick in, you know, there's no reason it should have been. You just sat the vial down and it would just like come out. So it was just those few vials. I haven't had any trouble with any other ones. So I don't know if it was just defective vials, defective lot, or what it was.
That's not against you. So like
Yeah.
what she said, if I'm the one doing the validation and that happens, I'm going to test it myself. I'm going to puncture it myself to see, okay, to see, and to actually do that check and balance that this is really a defective vial, okay? So that adds to the nerves when you're doing your validation. But we do understand things like that happen. Ms. Trisha has been in the industry 10 years. I've been in the industry more than 20 years. That's a giveaway of my age. But yeah, I've been in the industry 22, next year, 23 years. And I can't say I've seen it all, but I've had so much experience being in the hospital, doing compounding. I've seen defective ones, okay? Not only like what she's saying, not only demo vials or demo drugs, but also real ones, okay? There's that one bad apple sometimes.
You just hope it's not a really expensive drug, but the manufacturers will usually make it good. You just have to jump through a lot of hoops. So we had a factor product that we had trouble with, some Humate P, and those are really, really expensive. And so I had to go through that whole, send it, talk to them, give them, you know, send them the vial back, and I had to talk to a couple people and they had to send it to their lab, and, you know, so they could do all their testing on it too. So yeah, it happens.
This protocols Ms. Trisha is talking about, this is a company to company protocol, and you will learn this in law and ethics and inventory. How do we handle those stuff? How do we ask for credit? How do we return items? Those are all learned in inventory, law and ethics, and customer service. Thanks, Ms. Trisha. Do you want to finish up?
I'm finished, guys. I'm just wanted to say I'm very excited to be able to work with you guys in lab. I had a lot of fun on Monday. It was great seeing all you guys. You guys look so different in person. Even though I can't see your beautiful smiles, it was still nice to be able to see you in person.
I know. Some of them I just met the first time in person, like Joey, because his mom was my student. I've met him before, but he was way younger then. It was a kid, I think, my son's age.
Still a kid.
Yeah. And then I saw Nila the first time, so that was nice. And it's funny because when I walk in, and it's also the first time the students are seeing me, and they'll say, "Oh my God, you're that short."
They don't tell me that.
It's so funny. Oh my God, for you, oh my God, you're tall. You're really tall, right?
You're shorter than me.
I know. So my short students, when they see me, they get so excited because I'm shorter than them. Okay, so it's really nice to see you guys. You can tell how excited we are every time we're at the lab, how much I miss being in the lab. That's why my background is still the lab. Okay, I can't wait. I think I read something about the vaccines will be available to everyone by April, May. I was hoping that too. So we'll see how it goes. We still pray that the vaccines be effective so that this whole fiasco will come to an end. Okay, so we're hoping for the best, and I always say, after science, there's God. Science will try to do whatever it is. It is sometimes people will question because I'm into science. Like, yeah, science can do so much, but after science, there's God. I just say that. Okay, so I leave it at that. It's such a good class. I'm so happy for Ms. Trisha. Don't you think she did an awesome job? Yeah. Okay. For her,
I didn't bore you guys with my PowerPoint. I'll get better, guys. I won't need.
Yeah, that was really awesome for her full class teaching. Okay, for her full class teaching, outside of the initial one that we did when she did your review. She's very, very knowledgeable about the topic. That's why I said I am excited to update the Udemy class so that you guys and everybody else who's got access to it can have the most updated information. She actually gave you the most updated information, and I'm happy to be sharing that with you. I'm going to end this.